Okay, I hope I am live. And we'll get going here on our quiz. It's the third Thursday. It's pre-Halloween, pre-Thanksgiving. No, it's pre-Memorial Day. Unfortunately, I have to work, but whatever. Okay, here we go. Flank pain. In all the cases, it'll be 10 cases, it'll all be kidney. Flank pain, you're looking at the non-contrast scans, maybe a little bit of lobulation, lower pole of right kidney. I don't see any calcifications, but that process in the lower pole of the right kidney is a bit better defined. And here you can see it with contrast arterial phase. It's low density with the cystic component centrally positioned. And there it is, a complex cystic lesion. Now, if I told you this was a cystic renal cell carcinoma, you would surely agree with me. If I told you the patient had fever, you may be saying, well, could this be an abscess? Renal abscesses and cysts or infected cysts and cystic tumors can look very similar, and it can be really challenging. Here's the lesion on excretory phase imaging, and again, clinical history. Positive urine culture would push you obviously to infection, but you have to admit I've shown many cases of cystic renal cell carcinoma. Again, look at the age. As a 25-year-old rather than an 85-year-old, it's more likely infection. And this was an E. coli abscess, making the point very nicely that infection, particularly abscesses, can look like cystic tumors. And again, low density, often stranding around the kidney, perinephric extension, can be unilateral or bilateral, usually unilateral, but again, it can be somewhat challenging. And here was an article making the point: temporal changes in lesion size and morphology after antibiotic therapy provide confirmatory proof of diagnosis, which basically means you do not need to do a biopsy. And again, solitary or multifocal lesions during the early phase of pyelo or focal pyelo with abscess usually can masquerade as tumors. So a really nice case in that regard. Okay, another patient, fever, patchy enhancement right kidney, striated nephrogram. This is the arterial phase. And you can see it again as I widen the window, makes all of these abnormalities at the cortical medullary junction more obvious. You see it here, but look at the normal left kidney, cortical medullary differentiation, looks perfect. Here is that same thing on the coronal view, nicely showing the lower pole on the right side most involved. Again, somewhat of a cystic component, like the last case, as well as patchy interstitial changes. And this too was a renal abscess. Another case, FUO. Now you see stranding by the right kidney. The right kidney has a dilated pelvis, and the enhancement in the right is not as good as the left, and there's air in the collecting system. And yes, you can ask if the patient has cystoscopy or a scope put up the ureter, and the answer is no and no. And so when you start seeing air in the renal pelvis and in the calyceal system, yes, I've seen a case of fistula once, but invariably it's infection. And it's a very specific infection, beginning with the E word, emphysematous pyelonephritis. Air in the bladder wall, emphysematous cystitis. Okay, a really nice example of emphysematous pyelonephritis. Again, often a life-threatening infection. These are usually diabetics, usually patients who are from nursing homes. They've been poorly managed. Infection can be E. coli to Klebsiella to Proteus. And if the patient does not get treated aggressively, the patient can die. Often with emphysematous pyelonephritis, a nephrostomy tube is not going to work. You'll need to do a nephrectomy in many cases. And again, CT is really the ideal study for picking up the presence and extent of emphysematous pyelonephritis. Another patient, left kidney, small, calcified. Look at the lobulations and the calcification. It looks chronic, right? Well, what could this be? When you give contrast, the right kidney enhances normally. The left kidney has some enhancement, but still abnormal. What gives you these ring-like calcifications and a small kidney? You got to think infection. You could think infarction. If you think infection, it's not really the look you get with pyelo from E. coli or something like that. What it is classic for renal TB. Small kidney, rim-like calcifications is a very classic appearance for TB of the kidney. Okay, and just a couple of comments. TB can affect the upper and lower tracts. It can have a long latency period. Adult life is not uncommon when it occurs. Dysuria, flank pain, hematuria, and pyuria are common manifestations. Okay, fever. Now you know I'm going to have to get away from pyelonephritis, but one thing, pyelo tends to give striatonephogram, not anything so sharply marginated and so smooth and large. When I see areas of decreased enhancement and it's large and it's sharply marginated, you got to be thinking about infarct rather than infection, though we would admit that infarct and infection can overlap. And if you start looking hard at the patient's renal arteries, the main renal artery, you lose the branching here. There's amputation of the vessels. That's classic for a vascular process. You could even potentially think about a vasculitis. Here it is a little bit later, the wedge-shaped defects, and this was a renal infarct due to vasculitis. Really nice case. Another example, a burn patient 2 weeks post-surgery is now having the renal function elevated, and you look, the kidneys are enhancing, but the cortical medullary differentiation is poor, and the kidney size is large. And I told you a burn patient. Here's some delayed imaging, really poor enhancement. Well, in burn patients, you have all sorts of issues. One of them is with muscle destruction, you get rhabdomyolysis. With rhabdomyolysis, you get excretion into the bloodstream. You have a very high level of CPK, and that goes into the interstitial space and plasma, and then you end up with resulting injury to the kidney. Elevated CPK of at least 5 times the upper limit of normal is an important diagnostic marker of rhabdomyolysis. You can also see rhabdomyolysis in a patient who gets lost in the wilderness and they're dehydrated, but it's usually trauma in nature, okay? And so a patient also from burns with a lot of muscle and soft tissue injury, but you can also see it in severe trauma. Renal failure, okay, another case. But the kidneys are very dense, they look calcified, they're calcified and small. What gives you small calcified kidneys? Renal tuberculosis would be a good thought. Prior infarcts might be a good thought, but just total atrophy like that is unlikely. And calcification, again, I'd be pushing, I think of infarct because of calcification, but I gotta be thinking about infection, TB, but there are other things like oxalosis, primary hyperoxaluria with end-stage renal disease, small high-density kidneys, lack of visualization of function, a really nice case. And again, here's causes of nephrocalcinosis, and you can see on the cortical that primary hyperoxaluria sits up there really, really nicely. Okay, just some comments about nephrocalcinosis. So a very important diagnosis to consider. Another case, decreased renal function, and it looks like multiple cysts in the kidney. It's a 40-ish or 50-ish year old. There are multiple cysts, but doesn't have the look of cysts as in polycystic kidney disease, but it looks cystic. And if I told you the patient's kidneys a couple of years ago looked absolutely normal, so I just want to keep you away from polycystic kidney disease. What gives you multiple cysts in the kidneys? Infection, infarction, they give you scarring, loss of cortex, not multiple cysts. And here is a little bit later phase, really multiple small cysts noted. And the second case looks almost identical, right? Multiple cysts in the cortex, they're really tiny, well under a centimeter in size. several of them only a couple millimeters. And what are you dealing with? Lithium-induced renal disease. Patients on lithium for some of the things like depression, they're on it for a long time, they could get lithium-induced renal disease, and it presents with multiple tiny renal cysts, okay? Long-term use of lithium for mood disorders. And again, multiple cysts, you would think about polycystic kidney disease, though usually the cysts are larger. You can get small cysts also, but you do essentially always get large cysts. And again, cysts appear as multiple tiny hypoattenuating lesions. So a very, very nice case. Okay? And that's it. I hope you enjoyed the cases. I hope you learned something. I hope you have a great holiday weekend. I hope you have a great day. And I hope to see you again on CTisus real soon. Have a great